general characteristics. So I'm beating the horse to death here, right? Now that we've gone over this over and over again. The only thing I want to draw your attention to, though, is that most of them are aerobic or facultative anaerobic, except I spelled that wrong. For saprophyticus, I don't know what I was thinking. That should be saprophyticus. Okay? Which is actually an obligate anaerobe. That's an obligate anaerobe. Okay, but the rest of them fall into that neat category of facultative or aerobic. Okay, this is, so you guys saw this today pretty much. What is this?
Micrococcus luteus.
Yes. Micrococcus luteus, and it's growing much better than our weak ass samples that we have. Yeah, so Micrococcus luteus right there, characteristic yellow pigmentation, okay? All right, so coagulase. We know about this. So we're initially differentiating between Staphs and Streps, or excuse me, we're initially differentiating the Staph species with coagulase. So most of the strands are coagulase positive that fall under Staph aureus, and then you have coagulase negatives. Okay, common ones like we have on the board: epidermis and saprophyticus. I can't even talk anymore. Okay, that's just what you basically saw in lab today. A coag positive versus a negative control. Okay, I don't know if that's really what it looked like. Did it look like that for you guys? Or, yeah. Because those are, as usual, expired reagents. So, not too much sure. All right, clinically significant species. We're talking about Staph aureus first. So, mild to life-threatening because you can get septic from Staph aureus. Okay, adult nares, yes, in the nose of 20 to 40% of adults. You can have nosocomial infections and then increasing drug resistance. Case in point, like vancomycin resistance. The problem with Staph aureus is that you just have a lot of virulent factors. So, for example, these are some of the infections that happen. A lot of skin infections, abscesses, scalded skin syndrome. Another one is toxic shock syndrome that can happen as well. Very nasty stuff. There we go with impetigo. That's a nice looking crusty, what do you call that, carbuncle or I don't know, but it doesn't look too good. Okay, biofilm, again, you have a risk of forming the biofilm. Okay, now here are some of the factors. I would highlight this slide. Yes, I would highlight this slide. This looks like a very good short answer question. Pick 3 or 4 of these, okay? But let's look at these for a second. Isn't this interesting? Don't you know some people that are prone to staph infections versus not prone to staph infections? And for whatever reason, they keep on getting them from time to time, okay? Antibiotic administration, that's one, but chronic underlying diseases is usually a big one, all right? Then it's going to depend on your conditions of where you are. Skin injuries is a big one. Wrestlers get a lot of them, like in the, I think, the ear from the mats. But the thing is that I don't want you to forget is, like, don't necessarily always think of Staph aureus skin infection, because it does a lot of other stuff. Like, you can get pneumonia from it. Food poisoning is one of the major ones that you can get from Staph aureus. Here are some of the virulence factors of Staph aureus. This, again, is going to be short answer. Okay. Hey, at least I'm telling you, right?
Yeah.
Come on now. It's funny, I have the total wrong lecture in my hands. So I'm kind of winging this right now. Oops. Okay. So the peptoglycan tailoic acid, that's one for the gram-positives. Protein A is a big one for Staph aureus, and remember that one. Then you have, what?
Thing in the back there?
Yeah, yeah. Then you have the hemolysins, and then you have super antigens for Staph aureus. But that's kind of like your collective list of virulence factors. Okay, this gets into basically the enterotoxins. So there's 9 distinct enterotoxins. That would be a good multiple choice question. Okay? You're like, okay. So there goes with the enterotoxins. That's when you're talking about like diarrhea and vomiting, and that's the food poisoning would be caused by A, B, and D. Okay, TSS is toxic shock syndrome. That's enterotoxics B and C, and occasionally G and I. I know this sucks, but I would definitely highlight this slide because I'm sure I will multiple choice these questions. Which enterotoxins do TSS come from or whatever? Okay, so make sure you look at this. So we're building half the test in just the past 3 slides, right?
Yeah, on this.
Right?
That's scary.
Yeah. How do you say this?
Cytolytic.
Thank you. Toxins. Okay? That's going to be affecting RBCs and leukocytes. Okay? So we have alpha, beta, gamma, and delta. Not much to know about this. Enzymes that Staph aureus has. Coagulase, obviously. That's your virulence marker that we've been working with. Protease, lipase. I can't even pronounce the other one. That's why I skipped over it.
Hyaluronidase. And I only know that because that's what we have to make for extravagation if a nurse, something infiltrates.
This one, it actually hydrolyzes connective tissue, and that's what actually permeates the spread that you see, like the redness in the tissue is from that guy. Okay? Lipids of the skin present on the surface, that's from lipase. Okay? But collectively, all of those together are going to produce the spread of the disease. Here's your functions for protein A. So it's going to be in the cell wall of Staph aureus. Major ability is to bind the IgG, and it can block phagocytosis. This is why protein A is important. Okay? Epidemiology, there's where you have the colonization. So it's basically, you know, like everywhere, if you think about it, skin-wise. Community acquired, you guys have heard this, Staph, MRSA, and hospital procedures run the risk of Staph aureus infections. Okay, and here are actual infections associated with Staph aureus. I already went through some of these, but look, you even have meningitis as one of them as well. So it can do a lot of damage, for sure. Okay, resistance to penicillin, that goes back to the lactamase enzymes, okay? But take a look at the 80% of the isolates are resistant to penicillin. That's scary, okay? So that's why it's basically not even used anymore. Vancomycin, what is it, Lance? Vancomycin is usually their go-to for aureus infections, or no?
Yeah, that's, you're going to be on, if you're in the hospital, they're going to put you on that prophylactically too.
Yeah.
If you're having an operation.
It's pretty nasty. Okay, moving on to Staph epidermis. Okay, coag-neg, we know that. Predominantly hospital acquired. This one, I've said this before over and over, it loves like catheters or ports that people have. It can also have nosocomial hospital UTIs. There was a patient that I heard of that went into, he actually had brain cancer, and they were removing the tumor, and on the hospital equipment, somehow there was Staph epidermis that was still on the hospital equipment, ended up getting a biofilm infection on the bone. No, they had to remove the bone, and he was on IVs for about 2 months or something crazy, and then they had to put in like a mesh type of device to replace the bone. Crazy town because of Staph epidermis. I mean, it is pretty nasty. And you guys saw in here, for whatever reason, it might be our lab, but maybe not, that it was resistant to everything that we tried. So I don't know if that was a fluke or what.
And don't they have the VRE too, like vancomycin? Leukocidins, I found that word.
Leukocidins, okay. I'm glad. Because that would drove you crazy.
Is that one of those one of the virulence factors?
Yeah.
Okay.
Yeah. All right, and these are the biofilm action here, okay? Again, focus on this one as it would be a multiple choice question if I'm asking you specifically about Staph epidermis biofilms, because really that's what they do. They're just biofilm crazy, okay? All right. All right, Saprophyticus, I spelled it right on this one. So UTIs in sexually active young women. Let's see. Urease is a virulence factor, which is kind of interesting. Also contributes to bladder tissue invasion. Okay, this one there's not like a ton of information about it, but usually the go-to thing on this is that it's a UTI in the sexually active younger women, for whatever reason. Okay, loogie. This one, the most important thing for you guys to remember is like what I had on the board. It basically is echoing the same thing here. Is that positive clumping factor, but negative tube coagulase reaction. And that's why it's termed that it mimics Staph aureus, okay? Because you're like, what's up with this? It's actually giving me a coag positive, but in reality it really isn't. It's just playing around. You know what I mean? And it has a ton of different infections that it can cause.
It's just playing around.
Just a pain in the ass. All right, these are other coag-neg staphs. I'm not going to ask you about these. I just wanted you guys to get a feel for like the other ones that come into play like in the hospital. I mean, these aren't really seen that often. Okay, and I don't even think we have these in the lab. I don't think I could even show you these if I wanted to. All right, I don't know why I put this in here. Let's just guess that this is Staph aureus or something. I'm not even sure what's going on. All right, isolation and identification, BAP, of course. So we can look for hemolysis. MSA, we've gone over that for mannitol salt agar. And then remember, don't discount PEA agar. Here's basically the cultural characteristics of both of them. Staph aureus, you guys saw maybe a little bit here. It wasn't that great. The hemolytic zones, usually they're going to exhibit more of a yellow pigmentation versus Staph epidermis. Ours really aren't doing that great. Yeah, you're seeing Micrococcus luteus really yellow. And that's like when you talk about Staph aureus, that's usually what you're thinking of is Micrococcus. It should be that yellow.
To me,
yes.
Like the Staph aureus kind of had like a muted yellow compared to the Micrococcus.
Say that again? I missed
the
it.
Staph aureus, when we were looking at it, because we distinctly compared the aureus with epidermis because of the color thing, and we could tell that the epidermis is gray, but the aureus is like a muted yellow.
It's a muted yellow, okay. But Micrococcus, man, it's like boom, and that's like what they're talking about. It should be that yellow.
Oh, for aureus?
Yeah,
okay.
But for whatever reason, when we grow it in here, it's never that yellow. Okay, and that's exactly why don't base identification on the colony morphology. You know what I mean? Take it more steps. Do the coag test. Do MSA. You can have access to the Bacti Staph testing if you think it's Staph aureus as well. Okay, see if it clumps up. All right, identification methods. Micrococci, this is OF reactions, oxidative and fermentative reactions. We haven't worked with that yet. That won't be on the exam, but I just wanted to point out that that's how they differentiate micrococci from the staphs. We're usually going to ferment glucose, and of course the staphs are going to have a high salt tolerance. I think the MSA plates are around 8%, yeah, versus like normally everything else is like 2%, I think. Now, this is just to give you guys an idea. Here, I'm a huge fan of flowcharts. I mean, this might not be the best one that was ever written, but if you get in the habit of doing stuff like this, like for Staph, Strep would be an easy thing to do. This, I think, will really help you because visually you're seeing what's going on versus just looking at the notes over and over and over again. Maybe you need to write it out like this and it might help you. Kind of Christmas tree it, sort of. Okay? Do you guys have questions on this? You guys have done flowcharts before. Yeah, it's what you're doing in the lab, but you're putting it on paper. Basically, this is what you're
Use it
doing.
like a roadmap for your
It's exactly, think of it as a roadmap, but this can help you study it as well, okay? All right, antimicrobial susceptibility. We've gone over this. The only thing that really needs to be aware of is the novobiacin susceptibility. They use that to identify the Saprophyticus. And again, that was up here on the board, okay? Okay, and then simple points to remember, boom, all right? We've covered this. This is like a really short lecture, all right? And I'm telling you, I know this doesn't sound reasonable, but I'm not playing around. Keep going back to this. This is really what you need right here for Staph. Now, once we start talking about strep, then it's going to get like, confusing. But in the meantime, focus on that. Okay, you guys, look at this. This was one of the things I wanted to point out to you guys. So A is on solid media and B is on liquid media, right? Under a microscope. So actually B looks a little bit better, you know, and that actually might be the case when you get your unknowns. You might find that it's a little bit clearer in the broths versus the plates. Historically, that's really what it should be. Even though broths might freak you out a little bit, it might be actually to your benefit. Okay, so I'm just telling you that just so you get a little bit more confident, because the broth, you haven't really worked with that all that much. Okay, so Streptococcus and Enterococcus both are catalase negative, gram-positive. They behave like facultative anaerobes, but they're considered air-tolerant anaerobes. So what are the air-tolerant anaerobes? Which one? What do they look like in the tube? Do you remember that?
In the middle.
They're scattered. That's microaerophilic. Is in the middle. So facultative are what? They are all over the tube, but
all over the tube, but they grow on the top.
Yeah.
Per oxygen.
And air tolerant, you basically like
They're
just
gonna be on the
evenly
top
distributed. Okay. All right. And remember, with your streps, you have the carbohydrate identification with the antigens in the cell wall. That's where you get the Lancefield characteristics. Okay, so we're just jumping right in and we're going with the main organisms that you need to know. So we're going with Strep pyogenes, which is group A. Can cause rheumatic fever. Complications can be scarlet fever, pharyngitis. One of the big virulence factors for that is the M protein. This is actually attached to the peptidoglycan and extends to the cell surface. Then you have streptolysine that actually lyses the cells. And then you, again, it's the same thing as the Staph aureus. You have the spreading factor, virulence factor again. Okay? So not so good when you have that. Anybody know why that's not good, the spreading factor? Do you know what complications this can also cause, strep pyogenes? If not, we're going to get to it in a minute. What are you going to say? Endocarditis.
Rheumatic fever and endocarditis.
Yes, there's something else though that I'm getting to in a second. Might not be right this second. Pyodermal infections, so impetigo, cellulitis, which is pretty nasty. How do you pronounce the next one? Does anybody know? With the E. How is it?
Erysipelas.
Erysipelas? Is that erysipelas? I never can say that right.
Hey, I can say hi or Uranidase.
Erysipelas. We'll just say that, I guess. That's actually pretty uncommon. That's acute spreading skin lesions, which doesn't sound too good. Wound infections and sometimes arthritis. Now, this is the one that I was coming to before. Necrotizing fasciitis. The NF factor, right? With the spreading factor. That's like the flesh-eating disease. Okay? You've heard of that one, I'm sure. There was actually that girl that was zip lining somewhere on her spring break, fell off the zip line, and then was in the hospital, and boom, it started eating her legs.
Wasn't it anemia?
That's brain-eating thing. That's by Pam something. I'm losing the name right now. But yeah, that's something different. But that's brain eating. This is like actually skin eating. Okay, flesh eating. Yeah. Bye guys. Bye guys. So that's a result from a trauma, burns or laceration. But usually the port of entry, which is scary, is unknown. Okay? So they don't know exactly. This is like collectively what they'll say. It's a result of a trauma or something. But usually they really can't find the port of entry, which is creepy. Mortality rate is greater than 70% on that one. All right, and again, remember, this is caused by group A strep or strep pyogenes. Okay? All right, another really bad one, STSS, streptococcal toxic shock syndrome. Your entire organ system can shut down on this one. And again, most cases with this, the exact port of infection is unknown. Initial infection is pretty severe. You can have cellulitis or wound infections. Patients that have SPSS are often bacteremic, meaning bacteria in the blood, and or they have NF, necrotizing fasciitis. So imagine yourself in that condition. You're dealing with necrotizing fasciitis plus you have this. You're not going to be doing too good, hence the 70%, okay? Post-streptococcal infections, rheumatic fever is one. That's a complication that usually follows a strep pyogenes infection. That's usually characterized by fever and inflammation. It can be of the heart, joint, and blood vessels. And the attack usually occurs 1 month after the initial infection of strep pyogenes. So it is quite a long time beforehand. Then you have AGN. That's after cutaneous or pharyngeal infection, and that's more common in children. It's almost like a renal disease, but that's also considered a post-streptococcal infection. Okay? And again, I'm still talking about strep pyogenes, so we're still on that one. This one wreaks a lot of havoc. Okay? Laboratory diagnosis. Okay, first of all, for strep throat, you need proper sampling. And with that, I mean, they really have to get in there, and it's literally almost, the poor kid usually is like gagging for them to actually get it. You can't just scrape in the mouth or whatever. It literally has to hit the tonsils and like come out, okay? And that's not pretty when you have a little kid doing it, because usually they throw up. It's not good. I'm gonna shut that off, but blood auger plate usually, beta hemolysis, gram-positive cocci, usually with short chains, but you will see the chain pigmentation. The other thing is they're usually going by hemolysis for this one, because the hemolysis, as you guys saw in the lab, is so good for this. It's no mistaking that it would be strep pyogenes. The other thing is transport media is not required if it's under normal conditions. So they're not going to need Amy's or Stewart's or the charcoal if everything is kind of normal and there's not a big delay. You can just transport it, okay, without having any media with it. So it would be on the swab usually. All right, so that takes care of Group A strep pyogenes. Now you move into Group B strep Aggie. That's going to be your specific antigen is Group B. That's the capsule. So that's important as a virulence factor. Now, I've talked about this, that's a significant cause of invasive disease in newborns. The thing that I want you guys to remember on this is that you have an early onset and you have also a late onset. Okay, the difference is the 7 days. Okay, early is usually worse than late. Okay, but either way, the newborn's not in a very good position if they get it. Okay, and it's found in 10 to 30% of pregnant women as carriers. That doesn't mean that they're going to pass it on to their child. It just means that they're a carrier of it. And the other thing is that can vary from pregnancy to pregnancy. So just because you have it for one pregnancy doesn't mean that you would test positive on a second pregnancy. Anybody remember, what do they do if you do test positive?
4 hours before you give birth, you have to be on that antibiotic.
Exactly. 4 hours before you give birth, you're on IV antibiotics. Okay? Diagnoses is based on the biochemical test for strep Aggie. And of course, what's the biochemical test that I put up here? Did I put anything? Temporary hydrolysis, but of course we don't have that in the lab. And actually, what do you guys think? Ours looks similar to that a little bit, don't you think? It might have been a little bit more whitish, but pretty close. So there's strep Aggie on a plate. Okay? All right, strep pneumonia. So this is self-explanatory, it causes pneumonia, but you also can get infection of the sinuses, ear infections, bacteremia, and meningitis. Meningitis is a big one that strep pneumonia can cause, okay? Most frequently encountered children under the year 3 with recurrent ear infections, okay? The other thing to be aware of is that it is the #1 cause of bacterial pneumonia, is from strep pneumonia. Okay, and this is especially in the elderly or patients with an underlying disease. Lab diagnosis for this one, stains positive. Usually these are seen as diplococci. Pneumonia, really, you should put it on complex media. I think that might be why, in our case in the laboratory, we're not getting really good results of pneumonia on the BAP. They switched it over to chocolate, thinking that maybe that will help a little bit. There wasn't a particular plate, though, that I saw that we could be using, but I'm hoping that chocolate might be a little bit better. Between this and the Viridans, streptococci, optogen susceptibility testing is used for lab diagnosis. Okay, and what that is just a disc that they put just like a Kirby Bauer plate. Okay, it's just a small little thing. You can put it directly onto a BAP or a chocolate plate and then look for clearing around the disc. That's actually a direct smear of sputum from a pneumonia patient right there. Okay? All right, Viridans streptococci. These are normal microbiota of the upper respiratory. Viridans, usually they have green hemolysis, if they have hemolysis. They're opportunistic pathogens. Usually subacute bacterial endocarditis is what they're going to cause. They're also known for dental infections or gingivitis, oral infections, that type of thing. They're extremely difficult to identify and to isolate. So a lot of times these go undiagnosed, okay? So there's not like a whole ton of information on these guys, just that they're opportunistic and a lot of times bloodstream infections in terms of infection-wise, okay? And Viridans, I put down on your Lancefield, the group varies, so they're not in a group A or a group B. They're kind of all over the place. Okay. Enterococcus, previously classified as group D Streptococcus faecalis. It changed its name over a while ago. This one's non-hemolytic, or you have some strands that can be alpha. Identification is based on biochemical testing. Now, usually they're going to use bioescalin for Enterococcus, okay? And then they also can use a higher salt content. So you could use an MSA plate for Enterococcus as well. And that could differentiate. They can live in extreme conditions. This is why they're able to survive the higher salt content. They're frequent causes of nosocomial infections, particularly UTIs. And of course, they're going to show resistance to several antimicrobial agents. So these are a little bit harder to treat. On this one, basically I wrote that on the board, you need the hemolytic pattern, the physiological characteristic, the serological characteristic, and the biochemical characteristic. Okay, it's how they're going to base grouping the streps. That's basically what this slide is saying. Okay, do you guys? It's written on the board. It's actually underneath the pull down. Are you guys good with that, or do you need more explanation, or is that okay? Instead of going through this whole entire slide, that's basically what it's saying. Okay. All right. This is just a summary of the hemolytic pattern, and it's talking about that it's helpful, but it must be kept in mind that many species show variable hemolytic patterns, and we've been seeing that in our class, actually. The rest of this is physiological characteristics. This is very small. Some of them produce the pyogenic, are ones that produce pus. They're just talking about different little things in here. You're not going to be tested on this slide, but I wanted you to get a feel for some of this stuff. Okay, Enterococci, if you didn't know that, it's normal biota of the human intestines, that type of thing. So there's little things in here that will help for identification. Okay, and then the biochemical test summary. Here's your most used biochemical test for streptococci. We've only hit on a couple of these, but in the actual laboratory, you'd be using all of these kind of stuff, either a variation of all of them or some of them to test for streptococci. Okay? Do you guys have any questions on, just points to remember, kind of recapping? Do you guys have any questions on the streptococci? Just a little picture of the skin, because that's what we're going to talk about in this lecture right now. Okay? Overview of the skin biota. Okay? High concentrations of salt. lack of moisture, except for sweat, obviously. But there again, that's why you have a lot of the staphs growing on the skin, because they can tolerate a high concentration of salt. Take a look at permanent resident and transient colonizer. So permanent resident, we have Staph epidermis, epidermis meaning skin, of course. And then transient colonizer, you have Staph aureus. So it comes and it goes. Okay, you also have yeast, candida. Anybody familiar with candida? Candida albicans. Does that ring a bell? That'd be more opportunistic, I think. But Candida albicans is the one that causes thrush in the mouth, a lot of times with newborns. Okay. Just a picture there. All right, dermatitis. So these are just all different infections that I have listed on here, okay? And when I'm talking about dermatitis, basically it's just a general term that's going to describe an inflammation of the skin. And you're just going to have areas of redness and swelling, okay? So that's generally, in a nutshell, what is known as dermatitis. Now when you take that, you can look at different ones. So our very first one, you're talking about this one, and it's interesting because it's subjected to heat, moisture, and friction. So it's actually found most of the time in skin folds, in infants, or in obese adults, okay? And a lot of times they end up getting candida or thrush with this one. It goes hand in hand. On number 2, this will occur more often in men and obese and diabetics, and it's usually going to manifest in the groin or inner thighs. And then number 3, skin-to-skin contact. This would be, examples would be ringworm, jock itch, and athlete's foot. All fun stuff, right? Okay? So, molds. All right, pyoderma. When we're talking about pyoderma, this is going to be inflammatory skin disorders caused by bacteria, but they're going to produce pus. Okay, that's going to be the difference here. This is going to produce pus. So, impetigo. Anybody familiar with that one? Just as an overview, a little bit. Red sores. They're going to form pus. It kind of looks like chicken pox in a way. They're like small vesicles that become pustules, and eventually they rupture. Okay. This is like a cellulitis. Okay. This is going to involve the epidermis, dermis, and lymphatic channels. So this is kind of like not a great infection to have. Next one would be a soft tissue infection. And usually this is with handlers of meat that will get this, contaminated meat. And so they'll get these like lesions on their hands. Anthrax is considered one because you can have cutaneous anthrax as well as respiratory and inhalation anthrax. Okay, but cutaneous is fairly common. Cellulitis is another one. This is going to be inflammation and infection of both the superficial skin layers and subcutaneous tissues. And if you have recurrent cellulitis, chances are it's due to obesity. Okay? But cellulitis is not a fun thing to be in the hospital with by any means. And then, of course, MRSA is also in here. I've been talking about this with you guys a lot. The pimple that never comes to a head, but actually when you drain it, there's all kinds of pus that comes out. Okay? So all of these, they're pus forming, basically. That's a Staph aureus MRSA picture right there. Great under the microscope. Okay, other soft tissue infections. Diabetic foot infections, which is very common. This would include cellulitis, and so staphs and streps play a big part of this. Infectious gangrene, that's tissue necrosis and soft tissue, even when it forms gas, basically. Okay. The next one is a chronic skin infection and subcutaneous infection caused by fungus. Okay, and then the chromo is spreading mycosis of the skin and subcutaneous tissues, and you have scaly lesions that form, and this happens usually on the lower extremities. Okay, so if you guys are writing this down, make sure you know the differences between these, because these are going to be test questions. Okay, or go back and look at the video if you have to, but make sure you know all of these infections and what they do. That'll be a big part of the test. Nodular lymphangitis. Yeah, there's nocardia. All right, our first one is occupational disease. Usually they call this gardener's disease, and it will just go on the hands, and literally they're nodules that go on the hands. Nocardia can be localized or disseminated infection. It kind of depends on the immune state of the host. Mycobacterium cutaneous. There's one called marinum. This is open wound, or they call it the swimmer's disease. Usually you can get it from swimming, and you get nodule formations, or from like fish tanks, that type of thing. There's really good monsters inside me where a girl had one, and like they were gonna cut off her hand. I don't know if you guys have, I don't know, I laugh, I get nervous and I laugh. So that was a good one, but that was actually from that. And acetomucosis is a chronic disease, and you get abscesses and draining sinuses that discharge sulfur granules. That sounds fantastic. Okay, so those are the nodulars. All right, systemic and fungal infections. So Pseudomonas, we already know about that one. That's gonna like wreak havoc on burn victims, or usually it likes to do that. Okay, and it will discharge that blue-green pigment. So we're pretty good with that one. So you have Vibrio and Eremonas. These guys, again, you can just pick that up from seawater. It's easy, and you can basically get a systemic bacterial infection from both of those. Borrelia. Does anybody know which one Borrelia is? It's very common. Lyme disease. That's from Borrelia. How about the next one? We know that one. That should be familiar.
Is that syphilis?
Yes, sir. Give that guy a badge. Syphilis. That's syphilis. Okay? And then mycoplasm. Anybody familiar with this one? No? What if I say pneumonia? Walking pneumonia. This is the one that people will literally, that's why it's called walking pneumonia, walk around for months at a time with this like cough and like not feeling well, but kind of never get checked out because they don't feel that bad. And literally they're walking around and they have pneumonia. That's where you get its name from. Okay? So that's mycoplasma. So again, systemic bacterial and fungal infections. Okay, zoonoses. I think I said that completely wrong. The only one that I actually care about, you guys, you can like cross out everything besides rickettsia. Okay? I don't really care about the rest of them. Rickettsia, the one that I am talking about with rickettsia is Rocky Mountain spotted fever. Who knows what that is? I see you guys shaking your head yes, and then I see you shaking your head no. You guys look like bobbleheads.
I've heard of it, I just don't remember.
You don't remember?
I've heard of it before, I just can't remember.
So what do you remember? What do you pick it up from?
Somewhere in the Rocky Mountains.
From ticks.
Oh, okay, but no, I mean animal-wise. You pick it up from an animal.
Ticks?
Yes.
Yeah.
And it's
That
not
was
like
like a 90% chance.
yeah, I know. Right? It's like similar in a way that you would consider it to Lyme disease, except Lyme disease you go through 3 manifestations with Lyme disease. Like you get the bullseye rash with Lyme disease, then like the joints hurt, and then you can get neurological symptoms. This one is like less. It's like more mild than that, and you just feel lethargic, like Lauren right now. I think she should get tested.
I feel fine.
And just overall not feeling well. And then you'll actually go and they'll test for this, and then it will come back. And this one is actually a reportable disease. So the health department has to report this if you test positive for Rocky Mountain spotted fever. I'm not exactly sure why that is.
Well, I have been to the mountains last
I
night.
know it's reportable. So
You
and
did?
if you don't feel well,
I didn't
it
go to the
could be
mountains.
something.
I think because they try to control the ticks by
Oh, maybe that's
spraying
what it
the-
is.
Yeah.
That might be exactly what it is. So mycobacteria, that looks pretty awesome, doesn't it?
Yeah.
So you have non-tuberculosis mycobacterium. These are localized cutaneous infections, usually via trauma. And then you also have leprosy. That's also known as what? Hansen disease. Does that ring a bell?
I feel like I'm so close.
Okay, we're almost done, you guys, so thanks for hanging. Fungus. So that's pretty gross. Candida, as I mentioned before, that manifests itself usually as thrush. So newborns can get it, or a lot of times HIV patients can get that. And literally, if you ever have seen a newborn with it, it's like this white, it looks like a white mold kind of thing, like in their mouth. And you actually take, I can't remember what it is. You take something and put it on a rag and like wipe in their mouth, and it is supposed to clear out. It's something that you wouldn't associate with the mouth, though.
Like bleach.
No, not that bad. No, I want to say it's something to do with like the stomach.
Oh, okay.
Or whatever that that you like a Pepto-Bismol type thing that you would not think that it's related, but you kind of do that and the thrush goes away. It's very odd. So endemic fungus. They're going to often cause disease in healthy hosts as opposed to opportunistic fungi. Okay, and these are going to exist or can exist in the environment at 25 to 30 degrees. The yeast will exist at body temperature, and most of the time they're going to be seen in the respiratory tract. Okay? Alright, this is fun when we get into viral infections. So you guys are going to have to know this list. I can tell you that. So let's just take it from the top. So anybody want to stab at the first one? Ebola. What is that?
Measles?
Yes,
Yeah.
measles. And then you have rubella, which is basically the same thing.
It's a different kind of measles.
But this one they term this German measles.
German.
Yeah. Okay.
We
All right.
also rubella vaccine.
Yeah. Paravirus B19. Does that sound familiar? No? What if I say Fitz disease? Fitz, like number 5. Fitz disease. So basically what it is, it's 5 different viruses that they call, that's why it's termed Fitz disease. And what you'll see characteristically is slapped cheek. So it looks like a kid is literally like slapped in the face on both sides. The cheeks are very red. That's like the go-to sign that that's what they have, is from the cheeks. Okay? But that's from paravirus B19. Enteroviruses, these can cause basic rashes. Herpesviruses, I mean, you could spend 2 days just talking about herpesviruses. You have everything from what? Chickenpox to genital herpes, it goes everywhere. Herpes covers everything, okay? Your next one is a pox virus, and then you have human papillomavirus, okay, which would be HPV or warts, and then you have hemorrhagic fever viruses. So give me an example of the hemorrhagic fever viruses. What would be an example that has been in the news like all the time? Who said it? Yeah, totally an example of one, okay? All right, so that's your list of viral infections. Are you guys pretty clear on those? All right, good. All right, treat the parasitic infections that I just like happen to skip over. You can X those out. I'm not going to ask you anything about parasitic infections, okay? So X that out. Immune-mediated cutaneous diseases. You have DIC, okay? This is going to deregulate the blood coagulation system and usually lead to sepsis. Vasculitis usually happens in the lower extremities. And then immune complex disease, endocarditis, painful skin nodules. This can be located on the pads of the fingers and toes. Okay, so these are just examples of immune-mediated diseases. Versus the next one, which would be toxic-mediated cutaneous disease. So we talked about Staphylococcus scalded skin syndrome, and that one usually, like, the skin is literally just peeling off, like in layers. Okay, it's very, very painful, and it looks awful. Toxic shock syndrome. A lot of times, females will know this, right? That this goes back to tampons. If you have the tampons in too long, right, and you're not changing or whatever, you have a chance of getting toxic shock syndrome because of it just collecting the blood, okay? It's kind of gross. Scarlet fever is another one. What was that a complication of? Come on, guys. I know it's 3, but we just have one more slide.
Strep.
Thank you. I didn't even ask which one, but that's fine. Strep is here. Thank you. All right, lab diagnosis. All right, so swabs. Look at that. They might lead to false negatives. So they use a lot of times gram stains and other cultures. Tissues, so biopsies of the tissues are aspirates of the tissues are very more informative, okay? They have primary and non-select media, okay? And then they're going to still do biochemical tests and antimicrobial tests. And then for viral, they'll do tissue culture and they're going to look at cytopathic effects or like how is it affecting the person symptom-wise, okay? So that's how they'll go down the list with bacterial, viral, and fungus. Okay, guys?